page 22 in my lecture notes. Be sure to use the axial and appendicular DVDs as well as the bone chart. They're excellent guides for the anatomy of the skeletal system. You are responsible for everything on both DVDs and in the bone chart. I suggest making a flashcard for every bone in the bone chart, which is located within the syllabus. At this point, I know you've all watched the DVDs, probably several times, but if you haven't watched them since the first or second week when you were completing the survival checklist, make sure you continue watching them because that's been 6 weeks or so since you received the survival checklist. You don't have to go through the textbook and dig out functions for the bones or the parts of the bones. I give you that on the DVD. You don't have to memorize everything in the textbook. You've got a bone chart that shows you definitively what you're responsible for. So use that stuff. You want to learn more? Great, learn more, but master what you have to master first. Roman numeral 1, functions. Well, we've got, I guess, some obvious functions for the skeletal system. Support. And if you had legs, but you didn't have bones in your legs, you probably couldn't stand up. Structure, okay, that's kind of the same as support, but nothing wrong with listing it. We could say movement. So we're talking about musculoskeletal. What else?
Wouldn't protection go under there, like our ribcage?
Protection, okay, yeah. And you said like your rib cage, skull. What about another type of protection? We could pick it up in a few minutes, but what else?
Red blood cells.
Storage, okay. What did you say?
Red blood cell production.
Okay, so storage, production, and we've got calcium there. Production, you're talking about blood, and the word for that is hemopoiesis. Poiesis means to form. Hemo refers to blood. You said red blood cell production. That's true, but the skeletal system actually produces all of the blood cells. If you take the word hemopoiesis, again, blood production, and you take the words for the different types of blood cells, what word would mean production of red blood cells? Erythropoiesis. What would mean production of platelets? Thrombopoiesis, production of white blood cells. Leukopoiesis, so you're just taking erythrocyte, leukocyte, thrombocyte from histology and using this word to synthesize. So back to protection. Hint, hint, hint. What? Immune system, okay. So protection. This time we're talking about white blood cells. We're talking about immunity. I think I heard somebody actually use the word immunity. Okay, so there's a lot going on with the skeletal system. More than perhaps the obvious. Can't stand here if I don't have bones in my legs. But I'm not going to say this is a definitive list. It might be definitive. It's probably definitive, but you may come up with something else as you read and Google and etc. Roman numeral 2, organization. Oh, be sure to memorize the bone chart. Okay, so The first organization of the skeletal system is into axial versus appendicular. The easiest way to wrap your brain around that is to draw a stick figure. That's the axial skeleton. When you add the arms and the legs, you've just added the appendicular skeleton. So if you want to put that in words, the axial skeleton consists of the skull, vertebral column, ribs, sternum, and hyoid bone. The axial skeleton consists of the skull, the vertebral column, the ribs, the sternum, and the hyoid bone. The appendicular skeleton is divided into an upper division and a lower division, just like in the picture, corresponding to the arms and legs. I think organization is the key to everything, whether it's managing your finances or going to school. The skeletal system was organized for us before any of us were born. Let's not reinvent the wheel, let's use the organization. So we have axial versus appendicular, and then with appendicular we divide into upper versus lower division. Your bone chart is set up this way because it would be foolish, I suppose, to reinvent the wheel. On the bone chart, if you look at the columns, the column on the far left is always sort of the biggest picture. Where am I in the skeletal system? And then the column on the far right is the not microscopic, but the tiniest picture, you know, the bumps on the bone or the holes in the bone. And then the column in the middle is the bone. And let's just cruise through here very superficially in context of axial versus appendicular. So we're in the axial skeleton, which consists of the skull, vertebral column, ribs, sternum, and hyoid bone. Well, what part of the axial skeleton? Well, the cranial bones. We just work our way down. We change pages, but we're still in the axial skeleton. Must still be in the cranial bones because I didn't see that topic change. Here. Now we move from cranial bones to facial bones. Okay, so these would be cranial bones, these would be facial bones. Okay, so it's all part of the skull, but it is a little different. We continue working our way down, still in facial. Now we get into vertebrae. Vertebrae, of course, are the bones of the vertebral column. I start by talking about features common to most vertebrae, and then I get into the different types of vertebrae. So these typical structures of all vertebrae, so you're going to find those in pretty much any vertebra. You take the E off the word and it becomes singular, vertebra, vertebrae. But you have cervical, thoracic, lumbar, and so I talk a little bit about the differences in the different types of vertebrae. There's the sternum, the ribs. Looks like maybe the hyoid bone got left out, so you could add it right there. What bone does the hyoid bone articulate with? It doesn't. Somebody's watched the DVD. Good, good, good. Okay, then we have a huge change in the big picture, we move to appendicular. Remember though, the appendicular is divided into an upper division and a lower division. So this is appendicular, it's upper division. Within each division of the appendicular, we of course have the arms and we have the appendages. Within each division of the appendicular, we have the appendages, but the appendages have to be attached to the axial skeleton. So with the upper division, we refer to the clavicle and the scapula as a girdle. It's actually called a pectoral girdle. And that's what connects the bones of the arm, which going from proximal to distal, you'd start with the humerus down to the phalanges. So the clavicle and the scapula, again, constitute the pectoral girdle, connecting the bones, starting with the arm down to the fingers, to that girdle. Now, you can't put the ulna and the radius in a proximo-distal, because right there, so humerus, ulna, radius go together in terms of proximo-distal, carpals, metacarpals, phalanges. Big change here, we move from, oh no we didn't, we're still in the upper division. Big change here, we move to the lower division. Kind of like with the upper division, the legs have to be attached to the axial skeleton. So the innominate bones, or the os coxae, constitute what's called a pelvic girdle. So pectoral girdle, pelvic girdle. You've no doubt heard the term pelvis. So the innominate bones, or os coxae, constitute the pelvic girdle, and they're used to attach the bones of the legs to the axial skeleton. So the bones of the legs, femur, down through the bones of the toes, which again, just like the fingers, are the phalanges. So extremely organized, okay? So I encourage you to use this as opposed to just sitting there staring at pictures in the book. As we work our way to the right in the chart, as I've said, the left is your biggest picture, the right is your tiniest picture. As you work your way from the bone over to the parts of the bone, that's where you really want to use the DVD. You do not have to look up in your book what the lateral epicondyle is for. I'll tell you whatever I want you to know about it, either on the DVD or in this room, or one of the questions that I've selected from the lab manual on that chart that says, I suggest you answer these questions. So 90 to 95% of what you have to know, I'm basically going to just hand it to you. I'm not saying don't read the book, but I'm saying you don't have to go dig all this stuff out of the book. You just use the materials that I give you. Now, that was weird. Don't particularly like that. So you find yourself, help? Cursor, anybody?
Down there.
Okay. Let's pause right here. All right, so you find yourself either in the lab or in the pictures in the book at home, the library, whatever. You're looking at a hand. Again, whether it be in the lab, you've got the hand in your hands, or you're at home, you're in the library, you're at Denny's, you're studying a picture of the hand, and you find yourself wondering, my God, is he going to take one of these apart? I mean, I can easily say this is, the first, second, third, fourth, fifth metacarpal. These we went through long time ago in the context of proximal and distal, so this of course would be the first proximal phalange right hand. You remember that, that was on the first lab quiz. But is he going to take that stuff apart? You know, are we going to have to be able to tell this bone from this? Of course not. Archaeologists have trouble doing that when they find skeletons and dig them out of the ground to put them together in a museum. Of course I'm not going to do that. What about the bones of the wrist, the carpals? There are 8 of those. Am I going to take them? No, of course not. How do you know? Well, you can ask me. But you don't even have to do that. All you have to do is go to your bone chart. Carpals. Identify all in articulated hand. It doesn't say anything about identifying them in a disarticulated hand. Metacarpals, 1st through 5th. Of course, you already knew that. We covered that in the context of exercise 1. Note, when describing metacarpals and phalanges, Roman numerals must be used. Example, when a person hits the phalange for blah, 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 blah. So read this, guys. I've used the term before, owner's manual. This is your owner's manual. You have to read it, you have to use it. So, do you have to be able to identify? I don't think this thing likes not having a pad. Right, so do you have to be able to identify any of these disarticulated? No. What about the ankle? I don't know, let's see. So tarsals identify all in articulated foot, and talus or talus, you'll hear it pronounced both ways. Talus and calcaneus disarticulate. Okay, so that means that in addition to studying a foot, you'll want to find, and it doesn't matter whether it's a picture or bones in the lab, you want to find a calcaneus and a talus disarticulated so that you can study those. Are there surface features on the talus and calcaneus that you're responsible for? Why do you say there are? Do you see them in the bone chart? No. So what's that mean? Does it mean that they don't have any surface features? No, it doesn't mean that. It just means you're not responsible for them. You don't have to worry about them. Use the materials, people. Use the materials, okay? When I made the DVDs, I did my best to go through the bones in the order that they're in the chart. And as you know from the histology DVD, I didn't care at all about production quality because they were never intended to be mass marketed. I only cared about content quality. These are, of course, the same way, but I go through the bones, for the most part, in the order that they're on the chart. You know, so when you watch them, you want the chart in front of you, and whether, you know, that means you're watching them on a television-type monitor or on a computer screen. I don't guess that matters. But you certainly want to be in a situation where you've got a place to write so that, you know, you can jot down exactly what I say about every surface feature. A lot of the surface features are just going to be structural. There's not going to be much of anything to say about them. And then others, you know, like the foramen spinosum, I'll tell you that that's the passageway for the middle meningeal vessels. Or the foramen lacerum, I'll tell you that's the passageway for the internal carotid artery and the pharyngeal artery. And for the most part, when you hear those words, you've never heard them in your life. So you're going to have to hit pause and you're going to have to write it down. You're going to spell it phonetically, and then you're going to use the index or Google and get the spelling correct so that, you know, when you take your practical, you can spell it correctly. Histology practical, I generally take off, quiz 1 and histology practical, I generally take off only half a point for misspelled words. As we progress, I get to where I just mark it wrong. So spelling is important. Again, a lot of them are very, very simple. Sella turcica is where the pituitary gland sits. That's pretty simple to write down. Then the superior orbital fissure, that's pretty big. There are 4 different nerves that go through or structures that go through there. And so, you know, you pause, write, rewind, listen again, and so it takes a little time. But just do it, okay? Please just do it. We don't do that in this room because there's no reason to. There's nothing to be gained in this room by me putting a picture like this on the wall and saying, that's the foramen rotundum, that's the passageway for the maxillary branch of the trigeminal nerve. That's the foramen ovale, that's the passageway for the mandibular branch of the trigeminal nerve. That's what I do on the DVDs. That's why I made the DVDs. I don't have time to do it in this room. There's no reason to do it in this room. Now I pulled this particular picture up to try to make a point. When you start studying, I think the colored pictures are great because they make it easy to tell, well, this must be one bone and that green thing must be another bone and this must be another bone, because you could say it's color coded, not that there's a key down here telling you blue or purple is sphenoid, green is ethmoid, red is temporal. That's not what I mean by color-coded. I just mean it makes it easy for you to see one bone versus another. When you move toward, again, one bone versus another because of the different colors. But as you progress in your studies, you do want to progress from diagrams to actual photographs. And with the actual photographs, you have to see one bone versus another by looking at these joints. These joints are called sutures. And they're not difficult to see, but they're more difficult to see than, oh, I changed from blue to orange, it must be a different bone. The atlas is your resource for the photographs, okay? The textbook and the lab manual are going to be more your resource for the color-coded pictures, but the atlas is your resource for the actual photographs. So pictures in the atlas will look more like this. So we can see, nothing's ever as clear up there as it is on the monitor, but we can see, for example, the suture here separating the temporal bone from the parietal bone. We can see the coronal suture there separating the frontal bone from the parietal bone. We can see the external aspect of the greater wings of the sphenoid bone. We can see the little suture here separating the zygomatic process of the temporal bone from the temporal process of the zygomatic bone. Every word I just used, I show you on the DVD. I'm holding it in my hand, I'm pointing to it, I'm naming it, okay? They're so valuable. Please, please, please use them. know that, well, maybe somebody can tell me whether or not it works, but I know that Shasta attempted to post these pictures. Well, I don't know which set it is because there are a couple of different sets on a, I think it's called a Google Drive, and I don't know anything about a Google Drive. You guys probably do. But she was talking about that she used the pictures to make a phone book, kind of like you guys made a histology book. Over the years, some of the lab assistants, TAs, have said they made a bone book. Others have said they didn't make a bone book. Shanna, who's no longer with us, it sounds like she died when I put it that way. She's no longer with us. Just because she's like Krista, she graduated, she's an RN. You see her on the Facebook page, but she's busy working as an RN now. Anyway, she said the only reason she made a bone book is because her husband was deployed and she was a single mother and she couldn't take advantage of the open lab policy. She said that if she would have been able to, go to lab more than just her lab, she wouldn't have made a bone book. Shasta, on the other hand, did make a bone book. So you can kind of pick their brains. You can do what you want with that. But Shasta did say something about putting these pictures on a Google Drive. Has anyone been there, seen that? Can you verify it?
Yes.
So it works?
Yes.
It works, okay. So it's out there. I don't know anything about it. Ask somebody here that does, or ask Shasta. She also commented that if you couldn't get the pictures off the Google Drive, if you'll hand me a flash drive, I'll download them for you in the lab. And I did that for a couple of people on Monday. So.
Can we do that on Monday, sir?
Huh?
Can we do that with you on Monday? Bring our test drive?
Yeah. I'll be glad to do that. I've got four folders. Two are called appendicular and two are called axial. And I honestly, I don't know that there's anything there that's any better than what's in the atlas, but I'll be glad to share them with you. The pictures here called text pictures are straight out of your textbook, so you have those. And the ones called disorders you probably don't want. Some of those are rather frightening to look at. And we have a whole section where we talk about skeletal system disorders, and we'll look at them at that time. You probably don't want to put in a copy of them because some of them are not scary, but some of them are quite frightening. All right, Roman numeral 3. So as we start talking about bones, we encounter various shapes, and people like to anatomists like to classify things. So bones are classified according to their shape. And some of it's kind of common sense, but then some of it's kind of weird. For example, most long bones are long bones, but not all long bones are long. Okay? So if you take my femur out of my body, well, say my humerus, because that's what we've got a picture of. If you take my humerus out of my body, it's a long bone. And it is a long bone. But my phalanges are long bones too. And they're not long. Okay? So the classification is sometimes obvious, but it's not always obvious. So let's just run through these. And then two of the shapes we'll talk about in a little bit of detail. Well, I can't reach that one, but the flat bones and the long bones we'll talk about in a little bit of detail. So if you look at your notes superficially, Roman numeral 3, shapes of bones, I'm going to mention all of these, but then Roman numeral 4, I talk about long bones and flat bones specifically in a little more detail. We won't do that with anything except long and flat. So first of all, the so-called sutural bones, those are actually extra bones that form in a suture. It's kind of interesting. It's a good example of how we're all unique. Unlike a lawnmower, if you go to Lowe's and buy a particular model of lawnmower, and I go to another Lowe's and buy that same model of lawnmower, they're absolutely identical. I mean, they have the same everything because they were made on an assembly line. But people just aren't that way. Some of you have 2 left renal veins. Most of you have 1 left renal vein, but some of you have 2. It's just variation. So these sutural bones are extra bones that form in a suture. Again, the sutures are the joints between the bones and the skull. In the lab, to see a sutural bone, you would have to be looking at one of the real skulls. If you're looking at one of the plastic skulls, and those are really nice because they don't break when you handle them and whatnot, but they probably never put a sutural bone in a plastic skull. The plastic skulls, bones, whatever, are the stereotypical way things look. But if you have one of the real skulls in your hand, and we have only a couple of those because they're getting harder and harder to come by, you will be able to identify some sutural bones. The real bones are becoming harder to come by because many years ago, probably 15 or so now, the government of another country, and I won't name the country, realized that their citizens were digging up the dead and selling the bones to Americans. And so they banned the export of human bones from that country. So it's getting harder and harder now to find human bones. We do have some human bone clones, and they're some of the nicest bones that we have in the lab. It's from a company called Bone Clones. And the 2 skeletons that you see in the lab come from bone clones, and then we have 2 or 3 large black boxes of disarticulated skulls in the lab that come from bone clones. So the bone clones, it's like, let's say you volunteered to have your skeletal system cloned after you died. And so I buy a clone of your skeletal system, and it says you were a male, you were this tall, you were this old. It gives your ethnicity, everything we know about you. And so they're real. And so if you had a fracture as a child and there's a sign of that, we'd be able to see it. The 2 skeletons that we have in the lab, I don't know it off the top of my head, but somewhere there's a folder and it tells me, that whatever we know about those 2 people, one's a woman, one's a man. So the bone clone bones are super, super cool to look at. All right, that's sutural bones. Then we have irregular bones. Well, they're sort of irregular in shape. In addition to the vertebrae, you could put the sphenoid bone and the ethmoid bone in that category of irregular. And if you need of course I know you have your bone chart in front of you, but if you need a page number for the sphenoid and ethmoid, looks like page 26 in the bone chart, in the syllabus, which is the 2nd page of the bone chart. Right, short bones are, well, they're short. And short bones would include the carpals. What's like the carpals, but somewhere else?
Tarsals.
The tarsals. You could add the tarsals to this as another example there. Flat bones are flat, but here again we get into the some are obvious, some are not. The thing that makes a flat bone flat is not that it's flat like a piece of bread, but it has specific anatomical characteristics that we'll get into in the next Roman numeral. But for example, the ribs are flat bones. Now, if you're holding a rib in your hand, you're probably going to say it's a long bone. I guarantee you, if we go across the hall to the accounting class and we show them a rib, and we say, is this a long bone or a flat bone? They're going to say it's a long bone. But it's not. It's a flat bone. So again, the reason that bones are put in these different categories is not always obvious. So flat bones, other than the obvious, like parietal bone, ribs, sternum, clavicles. Those are all flat bones. Ribs, sternum, clavicles.
Are most bones in the skull considered flat bones?
Most bones in the skull are flat. The exceptions would be like the sphenoid and the ethmoid, which would be classified as irregular. All right, I mentioned long bones, and we'll talk about them in a little more detail in the next Roman numeral. Lastly, sesamoid bones. Sesamoid bones are bones that develop in a tendon. So, of course, the patella, that's your kneecap. Some people, not all people, some people have some sesamoid bones in their foot. Not everybody. Some people do. Okay, Roman numeral 4. This is where we talk about the two categories, long and flat, in just a little more detail. So this is a classic long bone. They're using the femur. As I recall, this works better if we rotate it. It makes the words a little harder to read, but you can turn your head if you want to. I don't know, do you like it better this way or unrotated?
That's fine.
All right, so a long bone has two ends and a shaft, but that's not what we call them. It couldn't be, could it? Because then it would make sense. It would be easy. Don't ever forget the elders. You sit around the huge oak table, make up all these words, pass body parts around. What doesn't have a name? What has only 3 names? What can we do to torment students in elementary anatomy classes? Ha ha ha! Hey, I've seen them. Most of them are over 100 years old. Ought to be put out to pasture. I had a statistics teacher like that. The name of the class was biometry. Translation, statistics for biology. Class met 2 hours a day, 5 days a week for 9 months. Teacher was 77, 78 years old, single, no living relatives, which is, why she continued working. She brought her dog to class. This was a tiny, tiny class. In graduate school, a lot of classes are very, very tiny. There were about 7 of us in there. We sat around just a table, kind of like a dining room table. And she had a little cubby right here. We had to take our shoes off when we came in the classroom, put our shoes in the cubby. And if you're thinking she can't do that, no, she can't do anything she wants to do. So we had to take our shoes off and put them in the cubby. And this little dog, not a Chihuahua, but that size dog. What else?
Probably a Pomeranian.
Rat terrier maybe rings a bell. Nasty, vicious
Wimpy?
little dog that snapped at us. So we're sitting there at the table with no shoes on, and the dog's biting our feet. We're kicking at the dog and hoping she doesn't see us. She used to beat her calculator when she didn't like the answer. So we didn't have dry erase boards, we had chalkboards. She'd put her calculator here, and then she'd erase, and chalk dust would fall on her calculator, and she'd pick it up and spit all over it, trying to get the... And she'd beat it because she didn't like the answer. I never trust it when I have to beat it in the middle of a calculation. Where's the dog? God almighty. And a take-home test is not what you want. You think you do, but it's not what you want when you have 2 weeks to do it. Anyway, that's all true. Crazy, crazy stuff. So yeah, I think about her when I talk about the elders who make up all this crap, but it's not really all made up. This goes back for ages. All right, so 2 ends and a shaft, but we don't call them the ends. We call them the epiphyses. So you change this I to an E, and you make it plural. So this is the proximal epiphysis, distal epiphysis. There are 2 epiphyses. The shaft is the diaphysis. So a long bone has 2 ends and a shaft. are two epiphyses and a diaphysis. Whether we're looking at the ends or the shaft, the superficial bone is compact bone. So whether we're looking at either end or we're looking at the shaft, the more superficial material is compact bone, also called dense bone. But if we compare the ends to the shaft deeply, we see a difference. So on the ends, either end, deep to the compact bone, we have spongy bone. But when we look at the shaft, deep to the compact bone, it's hollow. The hollow space is called the medullary cavity. If you actually had this in your hand and you're looking at the medullary cavity, it would kind of sort of look like you chopped down a tree, cut it longitudinally, and hollowed it out to make a canoe. It's exactly the way it looks, in fact. So, superficially, we've got compact bone on both ends and in the shaft. It's what's deep that varies. In the epiphyses deep, we have spongy bone. In the diaphysis deep, we have a hollow cavity called a medullary cavity. All right, what's in the hollow spaces or the porous spaces? The medullary cavity is hollow. The spongy bone is not hollow, but it's porous. In the spongy bone, we have red bone marrow. That's hemopoietic tissue, blood-forming tissue. In the medullary cavity, we have yellow bone marrow, which is fat. So red bone marrow in the spongy bone. Again, that's hemopoietic tissue. Yellow bone marrow in the medullary cavity, which is fat. So now you know why people use bones to season food. Need a bone, throw in a pot of beans. Need a bone to make a soup. Going to boil the chicken or the turkey carcass to make a stock. You're extracting the fat from the bone. That's where the flavor comes from. On the ends of the bone, not really shown here, well, not shown at all here, but on the ends of the bone, you would find hyaline cartilage. Now, if we call it hyaline cartilage, that's a histological distinction. What could we call it that would describe it to us functionally? Articular cartilage. So hyaline cartilage is histological, articular cartilage is functional. So I realize that's not in this picture, but add it, and I mean it should be simple because you learned that in histology. All right. Flat bones are the other type of bone that we look at in a little bit of detail, and they're pretty straightforward after having looked at the long bone. So a flat bone looks like a sandwich. The bread of the sandwich is compact bone, and the filling of the sandwich, the peanut butter or the ham, whatever you've got in there, is spongy bone. So you've got compact, spongy, compact. In the spongy bone, you have red bone marrow, just like you have in the spongy bone of a long bone. Roman numeral 5 called surface features of bones. The surface features are these things that I call bone markings. You could interchange bone markings with surface features. It's important to realize that while Roman numeral 5 is called surface features of bones, the point of Roman numeral 5 is not to go through all of these surface features in the bone chart. Where is that done? The DVD. So the point of Roman numeral 5 is just to give you some examples and tell you, for example, what is an epicondyle? What's the difference between an epicondyle and a condyle? What is a foramen? How come we use the word process so frequently? What's the difference between a tubercle, a trochanter, and a tuberosity? Just to define some of those different surface features. So now looking at Roman numeral 5, I divide the surface features up into articular, which means surface features involved in forming a joint, non-articular, and other, which would be foramen, openings, depressions, things like that. So in the world of articular surface features, a couple of them are head, and fossa. And you can describe those any way you want. There's no reason to quote me here, but I would say a head is a round, smooth, prominent end, and a fossa is a depression. And so very often what happens is a head articulates with a fossa to form a joint. Drawing from histology, what do we have here on the articular surfaces of these bones? Hyaline cartilage. Histologically speaking, functionally speaking, we have articular cartilage. Smooth, 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 smooth. Everybody's heard of arthritis. There are several types of arthritis, but in a nutshell, what's happening with arthritis, and if you have an older relative, you know, whose knuckles, fingers are all swollen and it hurts them to try to open the jelly jar, and what happens with arthritis is this cartilage begins to break down. Sometimes your body begins to attack that cartilage. Sometimes your body sees that cartilage as foreign, just as if you'd been invaded by bacteria. Your body attacks that pathogen, that microorganism. So it can be a devastating thing to deal with as it progresses. So a head and a fossa. A couple of examples of a head and a fossa. We could say the head of the humerus. And when I was learning joints, and I just had his name was Mike actually, he was a lab instructor. He said, here's what I do, and so I did it. I wrote them as equations. So the head of the humerus plus the glenoid fossa of the scapula that's your shoulder. And that's what everybody calls it. You can look the word up. It's a real word. Glenohumeral joint. That's an actual word. Glenohumeral joint. But nobody uses it. I didn't make the rules. I'm just sharing them with you. So if you want to learn your joints like this, great. But if you don't, great. It's totally up to you. Another example of a head and a fossa, we could say the head of the femur. So now we're going to be the hip joint plus the acetabular acetabular fossa or acetabulum. That forms the hip. Now, something to point out right here. It is necessary to say of the humerus because there is a head on the femur. It's kind of like if you say bladder. Which one? Gallbladder or urinary bladder? I'm pointing that out because it was unnecessary and redundant to say of the scapula. There's not another glenoid fossa in the body. It would be like if here I said of the os coxa. That's redundant because there's not another acetabulum in the body. However, you may not know that there's not another glenoid fossa. And so it might be appropriate for you to write it down, just as I did, because you're in the early stages, the learning stages. So I'm not saying you shouldn't write it down, but what I will do sometimes when I write down unnecessary information is I'll either underline it or I might put it in parentheses. And as you progress, in other words, if you were taking a different class that assumes you knew everything you learned in this class, you wouldn't write it. You just say glenoid fossa. So let all of this, let your brain process all of this as you grow and evolve in your understanding of anatomy. A similar surface feature to a head is called a condyle. Condyles are like heads, but they tend to be smaller.
Which is smaller?
A condyle. So it's the same deal, a head plus a fossa, it's just smaller. So without looking at pictures, just picture for me the head of your humerus, the head of your femur. Now picture the condyle of the mandible. Can you see that the condyle of the mandible is a lot smaller than the head of the humerus or the head of the femur? So the mandibular condyle or condylar processes completely redundant to say of the mandible. Plus the mandibular fossa of the temporal bone form the temporomandibular joint. Or the TMJ. Okay, so our first example, and I know you can't really see the surface features here, but looking at the shoulder, so there's the head of the humerus, there's the glenoid fossa on the scapula, both very, very smooth articular surface features. That's the humerus, proximal end up here, distal end down here. So there's the head. Nice, round, perfectly smooth prominence to articulate with the fossa on the scapula. At the other end of the body, there's the hip joint, that's the head of the femur. That very prominent fossa there, that's the acetabulum or acetabular fossa. This shows the acetabulum by itself. The pink tape or whatever is there because we're looking at an os coxa. Os coxae would be plural, your right and left os coxae. Put an E on the end, makes it plural. But an os coxa is actually formed by 3 bones. You see this laid out in your bone chart. There's a superior ilium, and then inferior and anterior there's a pubic bone. Inferior and posterior there's an ischium. Ilium, ischium, pubic. And the pink tape or whatever it is shows the lines of fusion. So from this point up is the ilium, from this point back is the ischium, and etc. So the way the bones fuse, we sort of change the name. We do that sometimes. I'll give you another example in a minute. But you can kind of see it right here. So we've got the right and left os coxae or innominate bones divided into ilium, ischium, and pubis. While this is up here, another point to be made with the bone chart is, how do I know when I have to be able to tell the right bone from the left bone? Well, you'll see right and left. If you don't see right and left there, got to be at least one where you don't.
The talus was down there, didn't have right or left.
The talus doesn't have right and left. Okay, good.
Just went past it.
This last example the temporomandibular joint, I want to talk about that clinically for a minute. If anyone wants to share, you're welcome to. I'm not going to ask you to or expect you to, but it is very interesting, and sometimes the student stories add considerably to what I'll say. So we're talking about the temporomandibular joint, and the clinical application here is a disorder called temporomandibular joint syndrome. The temporomandibular joint is, of course, your jaw joint. It's a hinge joint. It's shown right here, and it's a malalignment of those parts, and you've got those parts written down. You have the mandibular condyles of the mandible, which articulate with the mandibular fossa of the temporal bone. So you have a malalignment there affecting your opening and closing of your mouth. You can be born with TMJ syndrome, or you can develop TMJ syndrome. People that develop it often develop it secondary to an accident, a motor vehicle crash, where there's trauma. Another way that people develop it is through clenching their teeth. Sometimes people develop it just because their bite is not correct, and it's taken care of with the orthodontic procedures that teenagers often undergo. It can be exacerbating for the patient because it can present in so many different ways. It can present as jaw pain. You're talking to your dentist. Just, every 6 months you go get your teeth cleaned, and my jaws just always hurt. But it can be headaches. And so you're not at your dentist, you're at your doctor's office. You're talking about headaches. And it's because of your TMJ. The thing that makes it so terribly, terribly hard to deal with is it's a disorder best treated by an orthodontist, yet it's a medical condition. Now, you guys are different ages. Some are younger than others, and some of you, no doubt, are on mom and dad's insurance and don't really know anything about how insurance works. Others of you have your own insurance. So let me educate you very, very briefly. You have dental insurance and you have medical insurance. Your dental insurance pays for you to see the hygienist once every 6 months. It pays to get cavities and things like that taken care of. It pays for orthodontics. But the orthodontic coverage is very, very minuscule. Your medical insurance, on the other hand, pays when you have the cough, the sniffles, a stomach ache, your heart stops, you break a bone, you go to a medical doctor. Well, here we have a medical issue, a malalignment in this joint that is best treated by an orthodontist. We've got a big problem. We've got a big problem. A few insurance companies realize this, and the medical insurance company will let you see the orthodontist just like they let you see an orthopedic surgeon or an OBGYN. But most don't. And so people end up spending astronomical amounts of money. A simple splint to sleep with, to stop the grinding of the teeth, can cost $500 to $1,000. Your orthodontic lifetime limit on your dental insurance is $2,000 if you're lucky. If you're super lucky, it's $5,000. And it often doesn't cover anything after you're 18 years old, because what do you use orthodontic benefit for primarily? Braces. If you're 25 and you want your crooked teeth fixed, your orthodontic benefit doesn't help you. You should have done it when you were 15. It's a crazy, crazy world that we live in. So here we have a medical problem that needs to be treated by a dentist. An orthodontist is a dentist, not a medical doctor. So there's an option. Some people go to an oral surgeon. An oral surgeon is a medical doctor, just like an orthopedic surgeon or a cardiologist. But what's an oral surgeon going to do? Surgery? Okay. Orthopedic surgeon. What's an orthopedic surgeon going to do? Surgery? It's like talking about the difference between a psychologist and a psychiatrist. The psychiatrist is a medical doctor. They can give you drugs. So if you don't go to a psychologist, but you instead go to a psychiatrist, what are you going to get? Drugs. If you want to talk, you're going to go to a psychologist. If you want drugs, you go to a psychiatrist. Psychologists can't give you drugs. That's the only difference. So when you go to the oral surgeon, you get surgery on your jaw. And guess what happens?
Doesn't always help.
Doesn't always help, and worse than that,
More
makes
paperwork.
it worse. It's kind of like back surgery. Anybody know someone who had back surgery and they're worse after the surgery? It's almost always that way. So this is a nasty, nasty, messy thing to have to deal with, and I hope none of you ever do. No doubt some of you are dealing with it. You have, do you want to share? You don't have to, I'm
Yeah,
just,
sure. I just would have jaw pain in my jaws, and I went to the dentist, and they said, you know, you have TMJ, but I'm not supposed to chew gum or anything, because it like makes it hurt really bad. And when I yawn sometimes, it makes my jaw pop out, and my mouth gets stuck open, and it hurts pretty bad. And they wanted to give me a mouthpiece, so whenever I sleep that I don't cry, but it's
A night
expensive, and my
splint.
insurance doesn't pay for it, so I never bought it. So I just don't chew gum, try to deal with it.
so have you had braces to try to realign?
No, that's probably a good idea though.
Yeah, but it's expensive.
Yeah.
You know, that's
My
what
insurance
people
doesn't
get into as an adult. So we're gonna put you in braces. We want $2,000 down, and we want $150 a month for 3 years. Oh, and you need this $800 night splint too. Oh, insurance, no, your insurance isn't gonna touch it. Your orthodontic benefit quit when you turned 18. Or maybe your insurance does cover it. You got a $2,000 limit on your orthodontic benefit. You burn half of that getting the splint, and what's left doesn't even make the down payment on that. That's it, guys. That's how messed up it is. And so again, a few medical insurance companies, and we'll see it explode, we'll be dead, but over the next 100 years, it will become more and more common for the medical insurance to say, we'll pay for an orthodontist to treat this, just as we would pay for a cardiologist or an orthopedic surgeon. Are you?
How about a bite? Some people have a lower bite issue where they cannot really put their teeth together. Is that?
That's an aspect of TMJ syndrome. Absolutely, yes.
And they say that in order for that to be fixed, they have to break the bone of your jaw to kind of shorten it up.
That's what they say.
It doesn't matter.
Sounds horrible, doesn't it?
Yes, because my son is already on that too.
Yeah, that's and that procedure, what she's talking about, they break this part of the mandible, typically on both sides. They realign it, they shorten it most commonly. Sometimes they put fragments in there to elongate it. Then they wire everything together, including upper jaw to lower jaw, so that there's no movement. You drink through a straw if you didn't understand what I just said, and then you wait on everything to heal. Your son's going through that? God bless him. All right, so anyway, TMJ syndrome, your clinical application that goes with, for our purposes this morning, we're just exploring some of the different surface features. We're in the category called articular surfaces. So, all right, we're at a good stopping point. I know it's 5 minutes early, but I don't want to get into